Good. So that's actions, biosynthesis, regulation, the disorders. So we'll do hyperaldo first. Here are your players. And so you can get to hyperaldosteronism. Typically what they do on the boards, if they want to get you to hyperaldosteronism, it's a adrenal adenoma. Clinically, just to let you know, when we have a patient with hypertension who's poorly controlled, who has low potassium, metabolic alkalosis, and we get levels, we also worry about idiopathic adrenal hyperplasia. It's not a big ticket item for the boards. But what this is, hyperplasia, different than congenital adrenal hyperplasia. This is idiopathic adrenal hyperplasia. It's like both adrenal glands have little tiny nodules in them. That's how it behaves. So you have high aldosterone, but it's not from an adenoma. It's from both glands hypersecreting aldosterone. And then the other issue, so I'm making a point, and I'm calling these primary, and the phrase there is autonomous. This is autonomous secretion of aldosterone. Now, you can have increased renin levels, renin, angiotensin, aldosterone. And how do they describe renin? As the secretory product from the modified smooth muscle cells of the afferent arteriole. So high renin levels, either primary like autonomous or as secondary, you hypoperfuse the kidney, the renin level can go up. And that's what I'm doing here. So you can have physiologically appropriate renin secretion because you have hypoperfused. And again, in that instance, maybe the patient is hypotensive or what have you, decreased effective circulating volume. So you're not perfusing the kidney, and renin is going to go up appropriately, and that will drive aldosterone up. That's physiologic versus autonomous secretion with a reninoma. A reninoma, really rare, but you should just be aware of that. All right, so what are the manifestations? Here are the diagnostic criteria for primary hyperaldosteronism. Hypertension, hypokalemia, I'm talking about an adenoma now, right? Hypertension, hypokalemia, metabolic alkalosis, and a suppressed renin level. If you're autonomously secreting aldosterone from an adenoma, there's no reason for renin. That is the diagnostic criteria. Okay, so that's hyperaldo. Primary, we talked about secondary. We talked about the manifestations, hypertension, hypokalemia, metabolic alkalosis. How they're going to do the blood pressure is going to be severe on the boards. Hypokalemia, they can either give you a potassium or they do this. Patient having muscle cramps. They do that like with calcium, potassium also. So if they give you a potassium level, life is beautiful. It should be low, but be aware they can tell you severe hypertension and the patient has muscle cramps, metabolic alkalosis, they have to give you the labs, no particular sign or symptom. All right, so how do we get there? How do we make the diagnosis of hyperaldo? So here's the scenario. We have a difficult to control hypertensive. For the boards, they'll give you hypokalemia and metabolic alkalosis. What do? You get an aldosterone level specifically. So you have to have an elevated aldosterone level. But the diagnosis is really this aldo to renin ratio. That's the one that matters. Certainly from the point of view of the boards, if they give you this scenario here and a high aldo level, they're giving you very low renin as well. I never see where they express the ratio. They just give you aldosterone levels and or renin levels that are suppressed. But it makes sense. Renin is going to be suppressed. So hyperaldosteronism, adenoma versus idiopathic adrenal hyperplasia. And then this is a physiologic principle, and I don't want to beat it to death, but just be aware you'll see or hear about the idea of giving salt or saline loaded. Salt like salt tablets, saline come in and get an IV infusion of normal saline. And what are you looking to do? It's just you're making sure you're restoring blood volume. You're making sure the kidney is appropriately perfused. That's why they do it. Once the kidney is appropriately perfused, then we expect the aldosterone level to be suppressed normally. We're looking for a adenoma. If it doesn't suppress, then you have hyperaldosteronism. You can measure, although I'm talking about serum levels, you can also get a 24-hour urinary study for aldosterone. But in any instance, it's the idea of suppressing renin as a driver of aldosterone first. Like with all endocrine tests, you do a functional study before an imaging study. So the first thing we did was sorted out a high aldo to renin ratio, renin suppressed appropriately. Then once you have that, now you have to start sorting out where's that high aldo coming from. And at that point, that's where you could image the adrenal glands, and you're looking for either an isolated nodule or the bilateral adrenal hyperplasia. And lastly, in terms of distinguishing the two, sometimes you can't necessarily tell. You can do adrenal vein sampling. Is it just coming from an adenoma on the left side, or is the aldosterone level high bilaterally? Right? And if it's bilaterally elevated on adrenal vein sampling, you're not going to remove that adrenal gland. So that's the diagnostic testing in a patient for hyperaldo. And again, it was suspected based on the clinical presentation, hypertension, hypokalemia, metabolic alkalosis. All righty, so what are the additional derivatives they do? So this aldosterone escape, how does our sodium not keep going up and up and up? And how does our blood volume not keep going up and up and up until we kind of blow up? Well, because of this. Pressure natriuresis, and look at this urinary output curve. So here's urinary output, here's arterial blood pressure. As your blood pressure is going up, look what your urinary volume can do, right? So at very high levels. So you have this direct pressure natriuresis and diuresis, both sodium and urine. To normalize the sodium, we have ADH release. As the sodium goes up, ADH release goes up. The osmo receptors with the goal of normalizing p-osms. And finally, we have the natriuretic hormones as well. Okay, so these are the things that will keep your sodium at a normal value. And lastly, what else do we have? It's just treatment. Treatment straightforward enough. So aldosterone binds to a receptor at the principal cells, nuclear effects that increase pumps, increase density. So what do? We use an aldosterone receptor antagonist. And that's specific, right? Adverse effects of those agents are hyperkalemia. We're blocking aldosterone so the potassium go up. But I put in here, so that's the adverse effect, but it's also a beneficial effect, right? Potassium-sparing diuretics. So we can use a thiazide diuretic with aldosterone to hold on to potassium. That's a good problem. The hyperkalemia may or may not be expressed as a high potassium. More likely than not, it's going to be expressed by these bad boys. Tall, peaked T waves. So it's not just peak T waves. They have to be tall, peaked T waves. And they show you a tracing like that. What drug should be avoided? What drug is he on? What did they do to get here? So this is the language of hyperkalemia. So that's the aldosterone, I believe, too much part of the tour. So what's hypoaldosteronism, right? We just heard everything about hyper. What's hypo? Hypo's, right? The opposite. How do we get there? Right, so I already alluded to this. So failure of biosynthesis, 21-hydroxylase deficiency, we already covered that. Just emphasizing again, it's high index suspicion. You're just not holding on to sodium. Hypotensive, hyponatremic because of ADH, hyperkalemic. You just have to be on the lookout. And key thing here, again, why do you have hyponatremia? I feel like I have to explain myself, but right, we had aldosterone escape. It just doesn't apply to adrenal insufficiency. Adrenal insufficiency, you're not holding on to sodium, and big ticket item, where's that low sodium come from? ADH. All right, so now with failure of the adrenal gland, no cortisol either, primary adrenal failure, this is where you get this pathway here, CRH, propionate, melanocortin, ACTH, MSH. If they give you hyperpigmentation in a patient with adrenal insufficiency, that's great. How do you get to adrenal failure? So these are the main players, right? Addison's disease, and that's going to be classically associated with the hypopigmentation. You have these infiltrative disorders. So HIV can do it, TB, histo, metastatic lung cancer. As far as adrenal hemorrhage, those patients, they die, right? Those are described at autopsy. So you're not really getting into a lot of problems with electrolyte disturbances on those patients. So this is an aldosterone thing, but hypoadrenalism is hypocortisolism as well. So especially in patients with Addison's disease, what are some of the other signs or symptoms? Vitiligo, hypoglycemia, weight loss weakness, and we have no cortisol as well. Staying in with hypocortisolism, and it's really the story of adrenal failure. So we're talking about cessation of exogenous steroids here. And the big ticket item, when they say patient is on exogenous steroids, prednisone, what goes on to the adrenal gland? Where are we getting atrophy? And here's that idea of the ACTH dependence versus independence. So when you're taking exogenous steroids, you're turning off the hypothalamus pituitary axis, and you get atrophy of the fasciculata and reticularis because of turning off the central axis. But I already said the glomerulosa is ACTH independent. So the glomerulosa, and under stimulation from renin-angiotensin system, glomerulosa, right, aldosterone production is still intact. So since the aldosterone arm is still intact, with cessation of steroids, you actually don't necessarily get the electrolyte abnormalities. The diagnosis of adrenal failure is the ACTH stimulation test. It's not a cortisol level. We don't get a cortisol level baseline. People do it. If you have a high level, it kind of excludes hypoadrenalism. But in fact, in a scenario where they're giving you hypotension, weakness, pigmentation, electrolyte disturbance, if you're going to do the study, endocrine is functional studies. You give ACTH, and this is about adrenal failure. It also gets aldosterone in the equation, but it's adrenal failure, but we're measuring cortisol. So ACTH stimulation test is an easy test. You can do this in the ambulatory setting. You don't need to be an endocrinologist to do this. You have a patient you're suspicious of. You come in, you get a cortisol level at baseline. I give ACTH, and an hour later, I measure a cortisol. The cortisol level should go up. If it doesn't go up, you got adrenal failure, and then you just have to figure out why the adrenal gland has failed. And then ultimately treatment, of course, in that instance is just replacement therapy. So that's kind of it. So let's go on ahead and apply this stuff now to some questions.